All right, well, it is 12:15, so I think we're just going to go ahead and get started. And thanks for those of you who are here on time, and I'm sure other people will be joining us shortly. This is MCPAP Clinical Conversations, and welcome back to those of you who've been here before. And we're really happy about our program today, and we'll tell you about it. Just a reminder that this is the last of this season. So we always typically take a pause for the summer. So our next session will be in September and on the fourth Tuesday, and you'll certainly receive notice about that. So my name is Barry Sarvet. I'm the statewide medical director for MCPAP, and the topic for our clinical conversation today is early childhood mental health, and talking about MCPAP and the work that we're trying to do in helping pediatric primary care providers to work with mental health issues and preventive issues, and early identification of needs, for little ones, the 0 to 5, 0 to 6. So before we get into it, just a few housekeeping items. We do not offer CME at the moment. We were before, and it didn't work out for logistical reasons, and we're looking forward to resuming that in the fall, and we'll definitely keep you posted about that. We are, of course, recording the session, and the recordings will be available. So if you feel like referring and recommending to your friends and colleagues, definitely do that, because we want everyone to have access to the material that we're talking about. The slides will be on the MCPAP website, and the recording will be on the MCPAP website, and it should be easy to navigate to them under the toolkits and resources page. Our presenters will stop for questions at various times. I'm going to monitor the chat, so just enter the questions in the chat. And if you want to read them, if you want to just ask yourself, we can unmute you and just ask for that. But I'm going to gently interrupt the speakers if it's kind of appropriate to ask them to address the question in the course of their presentation. Otherwise, we'll save them for the Q&A portion. And then just a reminder to please fill out the survey after the presentation, because we're always looking for feedback to improve future presentations. So I'm going to go ahead and introduce the presentation team for today. Actually, we have Dr. Yael DeVere, our very own leader, within MCPAP for the West Central team, and she will be presenting with two of her wonderful colleagues. She will introduce them. I'm going to introduce Dr. DeVere. Dr. DeVere is a graduate of Hadassah Medical School, Hebrew University of Jerusalem, where she received her MD. And she did both her general psychiatry and child psychiatry training in an integrated program at UMass Medical School, UMass Memorial Medical Center. She is the vice chair of the psychiatry department at UMass Medical Center, and she also is the division director for the Child and Adolescent Psychiatry Division at UMass. She's an associate professor of psychiatry and pediatrics at UMass Medical School. She practices child and adolescent psychiatry clinically, and she also directs the Psychosis and Mood Disorder Clinic at the Center for Autism and Neurodevelopmental Disorders, the CAN-DO program. Her clinical interests are very wide, but especially include the association between childhood trauma and mood disorders, childhood psychosis, and the associations between childhood psychosis and autism spectrum disorders. So I'm going to now just hand it off to Dr. DeVere, and she will introduce her wonderful colleagues.
Thank you, Barry. I'm just going to start by trying to get those slides going. How are we doing? Can you see the slides properly?
We can.
Okay, great. So I just want to start by introducing my two wonderful co-presenters. And our MCPAP for Early Childhood team. So the first one is Carolina Clark, who is a licensed social worker. Carolina, you've got to correct me if I'm saying this wrong, but received her LICSW at UConn and is currently a fellow in the UMass Fellowship for Early Childhood, and has done some fantastic early childhood work already. Our second presenter is Kara Lindquist, who received her medical degree at UMass Medical School and her residency and fellowship in child psychiatry at Vanderbilt. Kara is an assistant professor for psychiatry and pediatrics and also our clerkship, our psychiatry clerkship associate director. So we are going to first talk a little bit about the MCPAP for Early Childhood program, and the order of this clinical perspective conversation is first that background, and then Carolina will model both what a call to MCPAP for Early Childhood looks like and what our echo sessions are like. And then Kara is going to share some early childhood content that we have shared with our echo participants, and we'll have time for questions. So as a background, this program has been funded through DPH, as DPH received HRSA funding for the Pediatric Mental Health Care Access Grant. So this is a 5-year grant. We're on year 2, on planning year 3, and the funds that came from HRSA are going through DPH Division of Pregnancy, Infancy, and Early Childhood, and the project is really designed to improve both training and support for pediatric providers and integrated care teams that are working to address the mental health needs of young children and families. There is also strong evidence that the COVID-19 pandemic really increased the concerns for the residents of Massachusetts around early childhood mental health concerns, especially in central western Massachusetts and communities like Worcester, Springfield, Holyoke, because these have been disproportionately impacted by the pandemic. So this was a wonderful opportunity to start the project there. And it also was designed to sort of give opportunities to strengthen some telehealth services and do some innovation in hybrid offerings. So this is really a partnership of our MCPAP team at UMass, DMH, Mass Health, and then the DPH Young Children's Council. So this is what this enhancement to the system and the program looks like. So the top part of the slide, you can see what MCPAP generally looks like, where the child and family contacts the pediatric practice with a question. The pediatric primary care provider contacts MCPAP, and through the phone, there is either care coordination to assist parents or primary care providers with access to services, or phone consultation, typically by a psychiatrist, that can either lead to advice on the phone in terms of how to manage the case, or a face-to-face evaluation by either a psychiatrist or a behavioral health clinician. So what are the early childhood enhancements? So the first part is that there is a component of training offered, which is echo training. Both DPH that designed training for integrated behavioral health clinicians and family partners, and this is based on the pyramid in primary care with some case consultations and a toolkit. And then there is the echo training that MCPAP team offered for champion pediatricians, so basically for practices that decided to join, and this was really centered on early childhood mental health training and case consultations. In terms of supports and consultation, there is also referral resources, and then a specialized toolkit. In terms of what MCPAP is able to offer, which Carolina is going to get into significantly more details with, there is the phone consultation that is triaged to the early childhood specialists. So rather than having the phone call for a child 0 to 6 go to the psychiatrist, as it usually does for the rest of the MCPAP programs, it goes to the early childhood behavioral health specialist. And if necessary, Carolina can offer a consultation, a multi-session evaluation, or some interim psychotherapy work. I do want to thank our DPH partners, so Kate Roper, who is the PI, and Larissa Mendez Pinata is the project director. Roxanne Hochchandler is the early childhood system coordinator and also served as our family partner for our ECHO. And at MCPAP, John Strauss for his leadership on this. So in general, why focus on children under 6 in this grant? So we do know that there is significant knowledge gap and lack of understanding of issues for young children, and significant lack in tools to identify and address those issues early on in a way that is more effective. And it's been identified that there is also a significant need for training, both for pediatricians who are the most trusted by families of young children, but also for behavioral health clinicians who are the ones providing this care. It feels like an area where training is not always sufficient to feel confident about the work. And we've noticed that there has been frequent requests for support in young children, especially in the Western and Central areas, which is why that area was chosen to start this type of work. Additionally, there really is a donut hole in terms of services between the age of 3 years and kindergarten enrollment. And that's because before the age of 3, there are early intervention services, but after 3, that isn't there anymore. And while public school systems are sort of tasked with assessing whether there is a need there, it is very difficult for them to do that when there isn't an actual diagnosis of a developmental or learning concern. So that creates a situation where those kids in that age group are not receiving enough support. So why do an enhancement? And part of that is the existing MCPAP model was really not enough. So MCPAP is a wonderful program, and it offers consultation all the way down to the age of 3, but the structure of the consult is such that it's a one-time phone support or one-time visit, and that doesn't really meet the unique needs of this population. And if you look at what DC 0 to 5, which is the diagnostic classification of mental health and developmental disorders of infancy and early childhood, suggests, it is that a diagnostic evaluation in this age group has to be conducted over 3 to 5 visits to incorporate developmental, relational, biological perspectives, and observation of the child and the caretaker child dyad, and to use some validated screening tools. So that really required us to think about design in a different way. And even without having a specialized team, we noticed that the volumes of requests with questions about very young children coming through MCPAP and being supported through MCPAP were quite striking. This is also here to sort of highlight the need for training. So this is a quote from the Massachusetts Infant and Early Childhood Mental Health Integration Work Group, suggesting that specialized training on supporting the behavioral health needs of the child, caregiver, and that dyadic relationship between child and caregiver is currently insufficient among both primary care and behavioral health providers. And this is really what we see in practice as well. In terms of use of the DC 0 to 5, so when we were building our program, we really used the philosophy of DC 0 to 5 and the practicality of DC 0 to 5 to think about the way we structure the assessments that we are doing. And this means that any assessments that are done are really including assessment of the caregiver-child relationship, psychosocial stressors, developmental issues, health factors, and clinical disorders, which I think will help explain the flow of how calls go and why they initially go to our wonderful behavioral health clinician who's an early childhood specialist. So some numbers here. So this is some numbers that we have to show that there actually has been a significant increase in the West Central team in terms of consultations received around children before their 6th birthday, so 0 to 5. So this looks at numbers of encounters. So you can see that to start, this was a region of the state that had more encounters for this age group anyway. But if you look at comparing similar times of year. So if you look at spring, April, June 2022 compared to 2021, there's been an increase there from 46 to 75. Similarly, if you look at summer, it went from 53 to 66. And if you look at the winter, we went up from 57 to 88. I think this is showing really some of the significant work that Carolina has done and Kara with making those consultations available. Additionally, we trained about 20 clinicians in 12 sessions focused on early childhood mental health concerns with our ECHO, and I'm going to talk about that next briefly. So as part of the program, we didn't just add an enhancement to the existing MCPAP model. We also created this ECHO series. So ECHO is a model of a virtual classroom that meets in irregular intervals and is case-based in its approach. It started in the University of New Mexico, and the idea was to really make tertiary medical knowledge available in rural communities. And the model of having sort of a team of specialists that sit in a tertiary medical center, but having participants from the community providers take part is really a great fit for what we've been able to do with this. This is just sort of a quick view of what our didactic schedule was like and what some of the topics were. So we really tried to follow both DC 0 to 5 in terms of chapters, but also some of the more significant concerns that we've been hearing about when taking calls from the providers in the community. So we really wanted to start with sort of introducing the approach to early childhood attachment and relationships, and then looking at ADHD, ASD, sensory processing, some sort of important issues that are challenging for parents like sleep, anxiety, eating, and trauma, as well as looking at prematurity and ending with use of medications, which very intentionally was left to the end of the course. And we also had an excellent session on culturally responsive lens and working with families. The way that an ECHO session work, and I'm mentioning this because we're going to try to do a little bit of a demonstration of that when Carolina presents her case, is that there's an introduction and a didactic, not dissimilar to what I'm doing right now. And then there is a case presentation, time for some questions and answers. So before allowing the entire class to give recommendations, it's not the job of the faculty of the course. It really is everybody who participates. We do want to set a good amount of time to ask more questions about the case before jumping into recommendations, and then there is a closing. So in terms of what the flow looks like, so I'm just going to say this really quickly, and then Carolina will really dive into what it is like. So there's a call from primary care on a child between the ages of 1 to 6. The coordinator asks the primary care provider if it's okay that the call will be returned within 24 hours. If the primary care provider says yes, then the message is sent to the MCPAP Early Childhood Behavioral Health Clinician, which is Carolina. She returns the call and provides support or decides to triage for an evaluation, and then there is the flow of what the evaluation actually looks like. So some of the differences between that and a regular MCPAP call is that the triage goes to our behavioral health clinician and not the child psychiatrist, that the response time is a little bit longer, and that there is the option of an extended evaluation and a short-term intervention option. So I'm going to pass this on to Carolina, but before I do that, I just want to say she will both demonstrate a case through this flow to show how the flow works, and also do this using some of the ECHO case presentation model. So when she moves on to that, you're more than welcome and encouraged to put in specific questions about the case in the chat, and Barry will convey them to Carolina as he is able to get them in there. So here we go. So I am done with my part. Carolina, take it away.
Hi, everybody. So I will explain a little bit of first how the call comes in, and then we'll go through a mock of the ECHO system classroom. So this call came in. It's all the information I get is there's a patient, 5-year-old boy, history of ADHD symptoms, and that now he's hearing voices. So my first step is, like Dr. Deere said, that the pediatrician is aware that the return call might take up to 24 hours. Then I call the pediatrician to gather more information and with the doc make a decision whether or not we need to do a full evaluation or just a conversation is enough. Next slide, please. So in this case, when I call the pediatrician or the primary care provider, the information I get is there's history of ADHD symptoms. It's not written here that the child had been previously on 2 different medications that were not helpful. Lately, the child has been talking about hearing voices and seeing people who are not there. Child is not currently, so at the time of the call, was not on any medication. PCP had done the Vanderbilt a year prior to this call, so when the child was 4, and it was high for inattention and hyperactivity and ODD based on mom's evaluation, but the ratings from the school were low. There were really no concerns from the school, but also aside from mentioning some sensory seeking behavior, child did have and does have an IEP. PCP describes the child as somebody as very impulsive and sensory seeking while in the clinic. And she related, I gave him the diagnosis so he could get the needed supports at school. The PCP also shared that the child had had occupational therapy for 4 months prior, but the parents stopped that service and the child continues to struggle at home. And at that point was also struggling at school. And the reason for this call specific was that the parents and the PCP were both really worried about these hallucinations. So then I meet with the family, and this is a case presentation. This is the ECHO form that we use, and we ask our presenters, whoever is bringing on a case for discussion. This is some of the information that we ask them, where the clinic is, demographic information about the child, how many providers in the clinic, do they have behavioral health supports integrated, and kind of what questions are they looking to be answered by the team. Next slide. So in this case, from my case, the child's male, age 5, identifies as Caucasian white, had been in the PCP's care since birth. We asked about barriers. There were none. Insurance, had private insurance. Diagnoses, PCP had diagnosed with ADHD and ODD, and their sensory, the OT, the sensory evaluation diagnosed the child with sensory processing disorder, and the concern regarding symptoms were he's very hyperactive and now is showing some auditory hallucinations, and it was actually visual too. He would see people that were not there. That's what was reported. Next slide. We also asked what services are in place? Does the child have an IEP? What's the living situation? Who does the child live with? Is the child attending public school, private care? Is there DCF involvement? We ask about family strengths and challenges. In this case, family had a lot of knowledge of community support. Is a safe home environment. Challenges at this point that were initially reported is that mom has anxiety and dad was recently diagnosed with bipolar disorder and PTSD. There was no trauma history reported initially for the child. Child was a healthy child, born full term, no issues with his medical situation. Next slide. So at this point, when I meet with the child, I meet with the family, the caregiver, so I can gather background information, and talk to them. Then I will meet with the child and the caregiver. I also reach out to any other provider involved in the child's care. I get information from teachers. And then once we finalize the evaluation, I also have the option of meeting with the family a few more times, if that's what's needed or indicated in the case. I can support the family with making referrals or trying to find resources available in the community. And if and when needed, I can refer to Dr. Lindquist, who works alongside our team, who's the early childhood psychiatrist, when there is a psychiatric evaluation needed. In this case, and Dr. Lindquist will go a little bit deeper into the diagnosing part of the DDC 0 to 5 and how it's done. But in the end, the clinical diagnosis, the child I maintained the ADHD combined diagnosis plus adjustment disorder, maintained the sensory processing disorder, no longer included ODD. And I want to talk a little bit about the hallucinations, but let me go through the rest first. Relational context, there was a lot of tension in that point for this family. Both parents were away from their jobs due to their own mental health concerns. So they were both on leave. There were a lot of challenges, a lot of tension in the home and the family setting due to that. No current physical health conditions as reported before, and psychosocial stressors. So this child had just joined a new school. Like I said, both parents were on medical leave due to their own mental health concerns, and which created a whole other set of issues financially. They were really concerned about possibly losing their house, and other challenges to the whole family dynamic. The developmental competence, there were no issues with the child's cognitive and physical health, and the emotional, social, relational, and communication were still emerging as the child was still struggling to express his wants and needs and really struggling to manage his emotional reactions. And the auditory hallucinations, what was really happening. So if you think, and then that's why it's really important to take a developmental perspective when you are doing these evaluations. When you think about a 4 or 5-year-old child, developmentally, where are they at? They're at the stage where they're becoming their own person. They're really separating from the parents so that the peers become really important to them. And that's the stage where their imagination is at the peak, right? So it's when we see imaginary friends. It's when we see the talking about, there's a dinosaur under my bed that helps me cross the street, because that's just the way they're able to communicate their thinking. And what was happening is this child, he would say that when he has a thought, then he would see and hear good mommy and daddy and bad mommy and daddy telling him what to do. So he would say, I want to do this, but then I hear good mommy and good daddy tell me that's not something I should do. So it wasn't really that he was hallucinating. It was just the way he was expressing his thought process in the best of his ability at that point. So there were really no auditory or visual hallucinations.
Hey, Carolina.
Yes.
I wonder, I understand that Yael was wondering if you could speak to the use of the Vanderbilt. This is obviously a relatively complicated, situation. But what are your thoughts about using the Vanderbilt for a child like this?
That is also another thing that I should have mentioned. The Vanderbilt is not validated for children under 6. Vanderbilt is validated for children 6 and over, and that's again developmentally children who, preschool children, 3, 4, 5-year-old, developmentally they're not able to meet those criteria. So if you do a Vanderbilt on a 4-year-old, it will likely come out positive, including for ODD, but it's not a true positive because it's not a developmentally appropriate tool to use. We use the preschool ADHD scale when we have concerns about ADHD. And that's something that happens very often, that a lot of folks do use the Vanderbilt to look at ADHD in younger children, and it's not appropriate. I hope that answers your question.
Indeed, and it's a very straightforward answer as well. It's great.
Next slide. So during my final meeting and appointment with the family, we discuss what the recommendations will be and what supports this family might need. My recommendations for this child was to re-engage in occupational therapy for sensory integration work, re-engage with therapy, incorporating family into the therapeutic work. And the reason for that is, a 4 or 5-year-old does not yet have the ability to generalize skills that you learn, let's say deep breathing or whatever they're learning to manage in therapy. They don't have the ability yet to generalize these skills to every setting. So they really need that outside regulation support and support in learning and utilizing these skills. So any treatment, any intervention for young children, preschool age, is really important to incorporate the family so that the parents also, and I suggested a parenting program, so the parents can also build their own toolbox to continue to support that child. I also did a couple follow-up meetings with the family to follow up on resources, referrals, and recommendations, see how they were doing. At that point, they were worried about whether or not you're still going to have the same insurance. So I met with them a couple more times to make sure he had the appropriate service. And we also included in this case, which it doesn't happen very often, at the end of my evaluation, if there is a diagnosis of ADHD, that's pretty straightforward. I have 2 options, or if it's a diagnosis that is not as common, maybe. Usually I'll refer to the psychiatrist, to Dr. Lindquist. But if it's a pretty straightforward diagnosis, ADHD, there are no other complicating factors, Dr. DeVere and I have come up with kind of a dot phrase, a recommendation for medication management that is included in my evaluation so the pediatrician can follow, which is very similar to what a primary care provider would get from a CAP consult in the regular MCPAP. Next slide. So if anybody has any questions for me, I'm happy to answer. Otherwise, Dr. Lindquist will.
Yep, so far, so good, or actually not good because we love questions. So you might as well carry on. Yeah.
All right, Dr.
All right, wonderful. Thanks, Carolina. So as Yael mentioned at the beginning of our presentation, our echo sessions consisted of a didactic component as well as the case discussion, which Carolina just so nicely demonstrated. So now that you've gotten a taste of what a typical case presentation might look like from Carolina, I'd like to use some of the remaining time to give a sampling of some of our didactic content and themes from our echo, much of which you will kind of hear some common themes and reiteration from what Dr. DeVere and Carolina shared. As there's a lot of good content in the Echo, selecting specific content to cover here was really challenging. And I would encourage that if our presentation today does pique your interest, we hope that you might consider joining some of our future Echo sessions. Next slide. So we'll start off with a definition of infant and early childhood mental health, which was kind of the first thing that we did with our ECHO participants. 0 to 3, a national nonprofit organization involved in both research and advocacy of early childhood development, offers the following definition. The developing capacity of the child from birth to 5 years of age to form close and secure adult and peer relationships, experience, manage, and express a full range of emotions, and explore the environment and learn, all in the context of family, community, and culture. And I added some of my own emphasis here to this definition. I really like it because it highlights the importance of relationships in the young child's family, community, and culture, which I think we can appreciate was really important in the case that Carolina just presented. We know that infant and early childhood mental health is often synonymous with the developing capacity of social emotional well being. And it's important to recognize that, like other domains of development, this exists on a continuum. So only a small subsection of children will be seen by myself or Carolina and warrant consideration of a clinical diagnosis. Next slide. And despite adopting a lifespan approach to diagnostic classification, the DSM-5 provides relatively little attention to the clinical presentation in children under the age of 6. 0 to 3 recognized this gap and designed a diagnostic classification system for young children, the most recent of which is published in the DC 0 to 5 manual. As seen here, and Yale briefly mentioned previously, DC 0 to 5 utilizes a multi-axial classification system for clinical formulation, and it helps highlight factors that might be contributing to difficulties, adaptive strengths, and additional areas of functioning which intervention may be needed for the young child and family. I'd like to pause and just recognize that many, rightfully so, will hesitate to diagnose young children, recognizing that normal variations of typical development exist. And while we want to always avoid over pathologizing or medicalizing common challenges that young children face, a diagnosis can also serve the purpose of organizing information into empirically supported, validated categorical classifications that can then provide information about expected trajectory and treatment responsiveness, and can also increase the young child's access to evidence based treatments. While each family may receive a diagnosis differently, for some, a diagnosis may be validating of their experience and may be received with a sense of great relief. But ultimately, the goal of any diagnosis is to avoid accumulation of distress and avoid delays in accessing appropriate supports and interventions. Without a developmentally sensitive, relationship based, and contextually driven classification system, children with atypical patterns of challenging behaviors or emotions may be labeled with terms that have negative attributes, such as bad, wild, or manipulative. And a nomenclature to disorders in early childhood provides a shared language that offers meaning rather than blame, which is so important. Next slide. Here you see the axes listed in a little bit of a different order. The DC 0 to 5 considers a child's clinical disorder only after issues such as the child's health, development, psychosocial stressors, culture, and nature of the child's relationship with important caregivers have been assessed. And excitingly, back in August of 2022, Mass Health released a bulletin supporting the use of the DC 0 to 5 framework as clinical best practice. So for any of those who are interested, 0 to 3 does offer DC 0 to 5 clinical training sessions. And there's also further resources such as a crosswalk to help assist in identification of DSM-5 and ICD-10 equivalent codes for reimbursement purposes. Next slide. As highlighted on Access 2, the young child must be understood, evaluated, and treated within the context of relationships. Winnicott framed this concept in his now classic words, there is no such thing as a baby. And by this, he meant that an infant or young child cannot be understood outside of his or her sustaining caregiving environment. That dyadic relationship between child and caregiver is influenced by factors unique to the child, such as their temperament, developmental status, their capacity for interpersonal relatedness, and also factors unique to the caregiver, such as their ability to understand the child, their stressors, and their culture that they identify with. The overall fit of the child and caregiver and their relationship is transactional. It's mutually influencing and dynamic and may serve to further perpetuate or ameliorate some of the strengths or susceptibilities over time. Next slide. So we can come to appreciate again that the child exists within unique relationships, community, cultures that can denote both risk factors as well as protective factors. And to serve any child or family, we need to appreciate these contexts. We're going to come back to the idea of cultural sensitivity in providing care towards the end of this presentation, which we also did in our ECHO. Next slide. So in the next couple of slides, we'll transition a little bit and talk about some of the concerns and diagnoses that we commonly encounter. And I've selected to focus on ADHD, sleep, and internalizing disorders. But instead of rattling off clinical criteria, epidemiological stats, et cetera, I'm really going to focus on how each of these example concerns or diagnoses can demonstrate some core tenets and challenges that may arise in working with this population. Next slide. So we'll kick things off with ADHD. I think many of us may be familiar with the symptoms of inattention, hyperactivity, impulsivity, executive dysfunction that go along with the diagnosis of ADHD and have to be present in at least two settings or two relationships, which is kind of one of the developmental shifts that DC 0 to 5 recognizes for this population. ADHD is one of the well classified and established diagnoses that can emerge in preschool age population. And we heard a little bit about kind of such a case from Carolina. There's many empirical studies, neuropsychological correlates, even neuroimaging studies that support the validity of the diagnosis. But I think as the case presented and demonstrated, an accurate diagnosis requires awareness and appreciation of typical development. Symptoms of hyperactivity in the young child can be difficult to distinguish from this highly variable normative behaviors that many children before the age of 4 or 5 might show. Furthermore, different families, communities, and cultures may have different opinions about the level of activity that's normative and acceptable. Deficits in attention compared to peers can also be particularly difficult to appreciate until later demands are placed on the child in a school setting. And then there's the fact that executive functions are thought to develop in a nonlinear manner during the first 5 years of life, which can make us pause and question, is this actually normal development or ADHD? And while there's recognition in the clinical criteria that the symptoms must exist in two different settings or relationships, not all preschool age children will have separate observers, particularly if they're not attending a preschool or childcare program. And even if they do attend one of these programs, staff in those programs may have varying levels of comfort in managing children with high activity levels or saying that this child's behaviors are outside of the norm of his or her peers. Next slide. Sleep. This is a very common concern that we see. I wanted to pull up this slide from our session to really emphasize that sleep and sleep related concerns are a good example of a complex interplay between biological and maturational factors with psychosocial and environmental factors. So we do know that biologically there's considerable changes in patterns and structure of sleep and wakefulness over a relatively short period of time between birth and the preschool age years. So there's consolidation of sleep towards the night. There's development of circadian rhythms. There's shifts and changes in terms of nap time and how much time is spent in each stage of sleep. Um, and although sleep in the past was thought of as a characteristic of the individual child, for young children, it's actually very important and necessary to consider the larger context of these relationships, family, and sleep environments in order to understand the development of both sleep wake patterns and the emergence of sleep problems. So, the schematic here depicts how sleep wake regulation develops in the context of a transactional model which is primarily influenced. You see that in the big circle by the parent or caregiver and young child's relationship. Um, Around the circle here, you can also see that caregiver factors, familial composition and stressors, environment, culture, and characteristics of the infant also all kind of factor into that relationship and are important to consider. According to this model, proximal stressors such as infant physical illness or maternal postpartum depression can directly impact the parent child interaction surrounding regulation of sleep and in turn can alter interactions with the family as well. At this age, sleep problems are often specific to particular relationships or settings. So the child may nap in a daycare setting or may go down differently for different caregivers. Um, and it's also important to recognize that there's a large influence of familial and cultural beliefs around sleep. For instance, how do you respond to a crying infant? Or are sleep aids okay to use, such as a pacifier or a lovey? And I think many of us are maybe familiar that our culture has very specific beliefs about what's okay with sleep versus maybe some other countries and even developed countries uh, some of our counterparts in Europe, which may adopt less of a focus on independent sleep. And then exacerbating this complexity of relationship among sleep and other factors is the large just degree of individual variability and the family's tolerance and definition of what constitutes a sleep problem. So those families who define their child's sleep as problematic may actually be more likely to report family or relationship problems stemming from the sleep problem and may respond to therapeutic approaches in the context of relationships. Next slide. And finally, we'll talk a little bit about internalizing disorders, which is a term traditionally adopted to include disorders such as anxiety and depression, which are also well established to occur within young children. I like to point out for many, it may be disturbing and counterintuitive to imagine a young child struggling with an internalizing disorder. The notion of an early onset depression, in particular, may conflict with this wish that some of us may have that early childhood be inherently joyful and a carefree time of life. There's also historically been a question among some whether young children are able to experience complex emotions such as grief or melancholy, guilt, shame, and the notion that any symptoms of anxiety or depression are generally nonspecific and transient and thus don't require specific interventions. And furthermore, while internalizing disorders can certainly lead to externalized or disruptive behaviors, oftentimes they may present more subtly. And this kind of paired with the less developed verbal skills that children have and more limited capacities of young children to describe their internal states often can translate into a risk of under-identifying internalizing disorders. Next slide. So, as Yale did mention, we specifically and intentionally chose to speak about pharmacological treatment towards the end of our echo session, and for good reason. It should be noted that there's very few studies to guide the use of medications in young children. Most medications are going to be used off label, and oftentimes FDA indications don't actually follow clinical practice. For instance, haloperidol and chlorpromazine, what many psychiatrists would consider as kind of heavier medications, and typical first generation antipsychotics do have FDA indication down to the age of 3 and 1 respectively. Similarly, Adderall, one of the mixed amphetamine salts, has an FDA indication down to the age of 3, although literature has really supported that methylphenidate derivatives are better tolerated. What we can say is that psychotherapy remains the mainstay of treatment for early childhood mental concerns. And even when pharmacological interventions may be considered, psychotherapy should continue in conjunction with medication. In fact, the largest medication study that we do have, um, the preschool ADHD treatment study, or PATS, reflected this design, in which all participants had to undergo parent management training for 10 weeks before they could even be considered for randomization for medication. And notably, one third of patients that were enrolled didn't actually have to advance to medications because they had a sufficient reduction in their symptoms. Um, in regards to when we may consider a medication, exceptions may be made when acute safety concerns are present or there's very significant impairment with perceived benefit from a treatment response with medication. And that's partly because our approach to medications is partly because children are more susceptible to side effects and adverse effects. For instance, in that PATS trial that I alluded to, 30% of parents reported either moderate or severe adverse effects in the children treated with medication. Next slide. So here's a nice schematic that shows the general approach to pharmacological treatment in preschoolers. It begins with that comprehensive assessment that confirms diagnosis, incorporating multiple sources and validated assessment measures. There's an adequate trial of psychotherapy, and if there's not sufficient improvement, then in conjunction with psychotherapy, pharmacotherapy may be initiated. But it's important to continue to very carefully document informed consent and continue to monitor symptoms and response. And it's appropriate to consider reduction or discontinuation of the medication after 6 to 12 months or symptom resolution. Next slide. In our final session, and what I would consider one of our most important sessions, afforded us the opportunity to take a step back and reflect on how to provide family-centered, culturally responsive care. Through our work with this population, we're working to reframe our focus from the challenging child or even the child with challenging behaviors to focus on addressing behaviors that challenge adult and peers. And this distinction in language is important because language does matter. In kind of reframing this, we're acknowledging that yes, the child is struggling, but I, as a caregiver, am also struggling to help them. And this may challenge me in terms of my ability to co-regulate or engage in reflective practices. And by really kind of shifting this, how we view such matters, we're recognizing that intervention is not solely going to focus on the child or solely focus on the caregiver, but instead really needs to focus on the relational component. Next slide. So we kind of come to these core tenets of cultural responsivity, which you can see here in this schematic. I want to highlight that providing culturally responsive care is a lifelong process that really happens in the context of relationships. And it happens both at the individual and the larger system level. And it really incorporates, and the spirit of it, it builds upon trust, fostering self awareness. A level of humility and curiosity, as well as suspension of judgment of both others and ourselves, especially as we're recognizing and identifying biases in this process. Next slide. So here's a couple of guidelines that I will leave you here to kind of ponder further. In my opinion, the opportunity to collaborate with families and partner together is what makes this work so meaningful. So oftentimes when families may come to Carolina or myself, we may face questions such as like, what should I do? How should I handle this? And I can tell you that like from my medical training, that can be a really uncomfortable question to receive because my medical training teaches me that I should be a quote unquote expert and be able to provide an answer. So if I were treating an ear infection, I could follow an algorithm and prescribe a certain antibiotic, and the patient is just, expected to get better. But in working with, engaging in this work, there's times where I have to say, you know, I'm not sure, I do not know, and recognize that what may work for me or for others that I've treated may not work for this particular child or family in their particular environment or culture. So really, kind of. My focus in my job is to partner and collaborate with you in thinking about what might work best for your family, recognizing that culture and community is going to be a big influence in that. Um, so with that, I know we have just a couple more minutes, but I wanted to see if there were any questions that I could answer, or questions for our entire ECHO team.
Kara or Yael, it's John Strauss. Maybe we should just spend a minute talking about what our goals with the grant are over the next few years, because I know some of the people listening are not in the West Central area. And do you want to take that, Yael?
I'll take that, and then maybe give Carolina some time to look at. There's a question there that I think, Carolina, you can probably answer about.
And we do have a bunch of questions which I didn't see until now, and so we have plenty of questions, which would be great.
Okay. I think we've been trying to type in responses as we went along, so just some of them I think we responded to, but the last one doesn't have a response. Kathleen, but to John's question, so, you know, we started in Central Western and we sort of came up with an approach and with a curriculum, but what we really want to do is make this accessible throughout the state. So we're very excited to offer a sort of 3-day training to all of the behavioral health clinicians working within the MCPAP teams throughout the state in the fall, so that all of the teams will have a capacity to sort of look at calls coming in this age range as first going to a BHC, and our BHCs feel comfortable doing that and triaging, and our team at UMass will sort of still remain there to offer support and consultation and a deeper dive if cases get more complicated. So that is one part. We're also going to have another ECHO in January, and hopefully that will be open for the entire primary care providers in the state, so not just Central Western. I think the last part, John, can we talk about the additional?
Sure.
Yeah, so there was a question earlier on, how is this different than developmental behavioral pediatrics? It really is different because we do bring very much a relational behavioral approach But having said that, we did recognize that many calls come in where the concern is there ASD? Can we get a diagnosis of ASD? So services are in place. So we're working on an expansion of our team where you're going to have a capacity to do some assessments for ASD that are going to be a collaborative process with a primary care provider. So a bit different than how a diagnostic evaluation works now through developmental behavioral pediatrics. And we'll be able to share more as this process is clearer, but that is part of the plan because that is absolutely an excellent point. There are always overlaps, and we do want to be able to offer all of the, to cover all of the needs of this age range.
And many places don't actually have developmental behavioral pediatrics. It's a pretty underserved specialty. So it'll be great for us to be able to help out, with that in the program.
Yeah. And finally, just to add, many of your practices now have embedded integrated clinicians, and we hope over the next few years in the grant that we'll include them to be more able to feel comfortable taking care of this population, because our MCPAP principles, we want to teach you to fish, not do the fishing for you. So that'll be part of the program as well.
I don't know if Carolina, you might want to speak to the question about really, sort of be able to engage with parents around parent training, because I'm not sure everyone's reading the chat, but I think it's a pretty important question.
So what I said was that it really has to be a cooperative, collaborative process. We really have to get to understand the family, their beliefs, their wishes, their needs, and their priorities, which might be very different from ours. And I really believe that whatever recommendation is made needs to be made after a trusting relationship has been established with that family. Because oftentimes we want to make recommendations and make suggestions, but if you don't have that trusting relationship with the family, it could either be not helpful at all, or it could be hurtful and harmful to the parent's relationship with the child. So it really is about building that relationship and that trust, and really making it a cooperative, collaborative kind of recommendation.
I just want to add one thing to that. I think that's absolutely spot on, but pediatric primary care providers are at such an advantage compared to our centralized team, where you go into this interaction already having so much credit and having had a relationship since, like in Carolina's case, the day the child was born. So what she has to do in rapid style to get to a place where she can have that conversation and make those recommendations, pediatric practices have that. So
it's a very challenging kind of pivot, because oftentimes the parents asking the pediatrician to do something, and you're sort of like turning it back on them and saying, oh, you need to do something yourself. And I think it's very nuanced, and I think leveraging that relationship, making sure that parents don't feel blamed, really talking about this as skill development, of special things that we've learned, can be really helpful. And also not imposing as Carolina said in her response to the chat, not imposing our values, on the, short of, child abuse reporting and things like that, that we have to respect, the family's values, and really understand the diversity in how people take care of their children, and honor that. Yeah. Well, it looks like we went over time, and I apologize for that. And thank you for bearing with us. And thanks to our wonderful, group of presenters. It was such a really nice presentation, and we're very grateful to have this program available, and for all the efforts that go into providing this as a resource to the pediatric community. So thanks, everybody. We will see you in September. And don't forget to fill out your questionnaire.